Now we are going to talk about perinatal complications in patient with having diabetes mellitus in pregnancy. So there are few complications that we are going to discuss, which are birth injury, polycythemia, hypoglycemia, neonatal, and we are going to discuss each one of these. I'm going to talk about this. Injury for birth injury, usually this is the injury including shoulder dystocia and brachial plexus trauma. This is both of these injuries are more common among infants of diabetic mothers, and microsomic fetus are at the highest risk. So most of the birth injury occurring to infants of diabetic mothers are associated with difficult vaginal delivery and shoulder dystocia. Although shoulder dystocia occur in 0.3 to 0.5 of vaginal delivery among the healthy pregnant women, the incidence is much more higher, which is 2 to 4-fold higher in women with diabetes. And common birth injury associated with diabetes are brachial plexus injury, facial nerve injury, and cephalohematoma. With strict glycemic control, the birth injury rate has been shown to be the only slightly higher than the controls, 3.2 versus 2.5%. Currently, clinical ability to predict shoulder dystocia is very poor. Warning signs during labor, such as labor protraction, suspected fetal macrosomia, need for operative vaginal delivery, successfully predict only 30% of this event. So, patient with the babies with the diabetes mellitus also can have polycythemia. How is it occur is when the central venous hemoglobin concentration is greater than 20, or we can say that hematocrit value is greater than 65%, which is not uncommon in infants of diabetic mothers, and is related because of the glycemic control. So hyperglycemia is a powerful stimulus to fetal erythropoietin production, and this is mediated by decreased fetal oxygen tension, and untreated neonatal polycythemia may promote vascular sludging, ischemia, and infarction of the vital tissues, including the kidneys and the central nervous system. So when the patient delivered during the delivery, approximately 15 to 25% of neonates delivered from women with diabetes during gestation develop hypoglycemia during the immediate newborn period. Neonatal hypoglycemia is less frequent when tight glycemic control is maintained during the pregnancy and in labor. Unrecognized postnatal hypoglycemia may lead to neonatal seizures, coma, and brain damage. That's why when the babies had hypoglycemia, we need to be very concerned about this. We need to monitor very thorough to the patients, because we don't want any complications such as neonatal seizures, coma, and brain damage happen to the babies. They may also have neonatal hypoglycemia. Up to 50% of infants of diabetic mothers have low level of serum calcium, and then probably this change of in calcium be due to the functional hypoparathyroid. However, the exact pathophysiology is unknown, not well understood, and with improved management of diabetes in pregnancy, the rate of hypocalcemia has been reduced to 5 or less. The patient may also have postnatal hyperbilirubinemia, which occurs in 25% in infants, and which is 2 times more than in a healthy population. The cause of hyperbilirubinemia actually are multiple, but the prematurity and polycythemia are the primary contributing factors. And increased destruction of the red blood cell contributes to the risk of jaundice and chronic icterus. So the treatment, because of the high bilirubin, is usually with phototherapy. However, if it's very high, exchange solution may be done. So for this is patient with diabetes mellitus also has high probability for their infants to have respiratory distress syndromes. The non-diabetic fetus achieve pulmonary maturity at a mean gestational age of 34-35 weeks, and by 37 weeks of gestation, more than 99% of the healthy woman infants have mature lung profiles, as assessed by phospholipid assays. However, in a diabetic pregnancy, the risk of respiratory distress may not pass until 38.5 weeks. Until recently, neonatal respiratory distress syndrome was the most common and serious morbidity in infants of diabetic mothers. So in the 1970s, improved prenatal maternal management for diabetes and new techniques in obstetrics for timing and mode of delivery resulted in dramatic decline in its incidence from 31 to 3%. Nevertheless, respiratory distress syndrome continues to be a relatively preventable complication.